Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Hello, everybody. Welcome back to Between Two White Coats. Amber and I have the distinct privilege of having Katie Webster with us today. Katie is a FNP, that's a family nurse practitioner. And we got to know Katie because she has been a consultant for us in starting our own bone health and osteoporosis clinic. Katie she was an ICU and ER nurse, and thank you for your years of service doing that. That is not easy work. And then she went on to become a nurse practitioner and spent really a career of 16 years or so working in an osteoporosis clinic. Her osteoporosis clinic was attached to a gynecology office. And
correct.
I think that's always really interesting because I think one of the things that people need to understand about osteoporosis is no one takes ownership for it and it falls nowhere. Is it the rheumatologist? Is it the orthopedics? Is it the gyns? Is it the primary cares? Is it the endos? And it can be any of those people,
right? And
it can be none of those people. And there aren't very many osteoporosis clinics, and there aren't very many people who just simply take ownership for osteoporosis. So tell us, how did you fall into a career of osteoporosis?
Well, it's actually kind of funny. It was never my great life's passion or life's work. I was really excited to be in OBGYN, working with women. And when I had just started my job, the physicians that I worked with actually asked me to go become a certified clinical densitometrist to gain that level of expertise in interpreting DEXAs and treating osteopenia and osteoporosis. And when you're brand new, you don't say no.
Right.
So I agreed to go get trained. And about 6 months into my practice, I went and took a course through the International Society of Clinical Densitometry and became a certified densitometrist. And the thing that just really, I think, ignited my passion for it actually goes back to what you had said earlier. Osteoporosis is really the orphan of healthcare. It primary care a lot of times is too bogged down in other problems to address bone health. It sort of falls through the cracks in a lot of ways. And our practice had a DEXA machine that our doctors wanted to be able to utilize more effectively and raise the standard of care for osteoporosis. And when I learned how underdiagnosed and undertreated it is and how significant of an impact it can have on a person's overall health, it really just ignited my passion, and I wanted to know more, and I wanted us to do better.
Yes, and I love that you say you wanted us to do better, because myself and our nurse practitioner, Scotty, have recently also gone through the densitometry course to learn how to read DEXA scans and learn what to do with the abnormal DEXA scans. And we did the Bone Health and Osteoporosis Foundation training course, CME course. And every single day we would run into each other and go, we know nothing about osteoporosis. Truly, I went through medical school. I went through family medicine residency. I practiced for many, many years, and I do a lot of geriatrics. And yet nobody took any time to carve out education on osteoporosis. It's really something that I think clinicians need to go and find themselves. And we don't do what we're not comfortable with. We are well-trained people who know a lot about a lot. And so I think we tend to shy away from the things that we don't know as much about. And osteoporosis is one of those things that really nobody's getting the training in. And so we're sort of, I got 500 things I can talk to somebody about in a primary care visit, most of those things I feel like I have some knowledge base on. So if I don't have knowledge base on something, I'm not going to bring it up. I don't think we're trying to ignore this, but we are ignoring it across the board. And it's creating really negative outcomes.
It is. And what people don't realize is that osteoporosis is incredibly common and can have significant effects on your health. 50% of women over the age of 50 will break a bone due to osteoporosis.
So let's just sit with that for a second. Half of the people. Now, if half of the people were having any other diagnosis, we would be so on top of it.
We would.
Half of the people will break a bone and be diagnosed with osteoporosis. And so, first of all, super common. So it should be pushed closer to the forefront. And the only reason that really common things aren't getting much attention is because, well, they just don't really matter. They don't really have bad outcomes. How is that true of osteoporosis?
Well, no, not at all.
Not at all.
But there are a couple of problems that I think contribute to it being so underdiagnosed and so undertreated. I'm going to go ahead and wave the pink flag and say, because 80% of osteoporosis patients are women, there's not nearly as much funding and research for women's health problems as there are for problems that primarily affect men.
That's right. And you can get mad at 3 women sitting here saying that, but you feel free to Google search that and see what the funding looks like. It's not a lie.
But the truth is also that 1 in 4 men over the age of 50 will break a bone due to osteoporosis. So men are more likely to develop osteoporosis than they are to get prostate cancer. And women are significantly more likely to break a bone due to osteoporosis than they are to be diagnosed with breast cancer. And yet it still continues to be, like I said, that orphan of healthcare. But it has a significant impact. Fractures have a significant impact. Osteoporosis is painless. Okay. Losing bone density doesn't hurt.
Doesn't. And let's just differentiate really quick. Osteoporosis versus osteoarthritis. They are not really related.
They are not the same at all.
They are not the same at all. So you can have joint pain. Wear and tear arthritis is osteoarthritis. It's not going to kill you.
It's painful.
It's painful.
Yeah, it is painful. And it does affect quality of life.
Yes.
And there's a common misconception among patients that osteoarthritis and osteoporosis are similar. And I do spend a lot of time explaining why the knee pain or the hip pain is not related to their bone density, but to, a degenerative arthritic type of condition.
I think too, like you're saying, it's painless until it's not.
Right, until bones start to break.
Yeah, and then we're following up with patients, but almost, I feel like we do a good job, and I'm not saying that other people don't, but often when patients have fractures, you're like, well, you're 80, you should be breaking bones. Like it's almost like
that's not true.
Exactly. But I feel like as a culture, we're like, well, they're old. Of course they're going to break something when they fall.
And when they're old and they break something, it's not like your 13-year-old's clavicle fracture.
Yeah.
This is a horrible outcome when you are older and you get a fracture. The odds of you returning to normal life are less than half.
Correct.
And so if you want to live independently or stay alive, you don't want to break a bone in older age.
And I think it's important too to talk about what type of fractures osteoporosis patients experience. These are not fractures that come as a result of falling off of a ladder or being in a car wreck. These are the type of fractures that occur with just normal everyday activity. Hip fractures can occur just walking down the sidewalk.
Yeah.
Any fracture that occurs as a result of a fall from your own standing height or less past the age of 40 is considered what we call fragility until proven otherwise. So a fragility fracture is something that would not have occurred in someone with a healthy skeleton. So let's say that I trip going down the hall and I fall on my wrist. Hopefully at the age of 44, my bones are strong enough that I won't fracture my wrist if I trip and fall. But a person with osteoporosis can experience a devastating wrist fracture or even a spinal or hip fracture from a simple bump or fall. And those are the fractures that really have a negative impact. You mentioned that, less than 50% of people get all of their function back after a fracture. And I don't think people really understand what that means. What that means is that 50% of people who have an osteoporosis related fracture, especially a hip fracture, are going to lose some aspect of their functionality and independence, whether it's requiring the use of a cane or a walker as an assistive device following a fracture, whether it's losing the ability to drive yourself, or even live at home. It's even if you don't die from complications following a hip fracture, which does happen, you run a significant risk of not being able to return to your life as it was before. And I just think that there's such an opportunity for us as healthcare providers to address all of the things that we can do, not just to treat osteopenia and osteoporosis, but to prevent it.
So you've said a couple of things that I just want to put a little focus on. And then there's so much more that I want to ask you. But one is the fragility fractures. And, I kind of wish they were called something else because people go, well, I'm not fragile. But please hear Katie when she says, if you are walking and you trip, a fragility fracture doesn't mean that it couldn't have been a hard fall. But when you fall and you haven't fallen from a ladder or 2 stories, you should not be breaking bones. And so if you are breaking bones, then that is a fragility fracture. Please expand to us. Most people think, and in a prior episode, we discussed your T-scores and your bone densities and coming up with your osteoporosis diagnosis based on that. But explain to us that you could never get a bone density and you can get an osteoporosis diagnosis. How does that happen?
Well, actually, there are 2 ways to diagnose osteoporosis. One you've already touched on, which is the DEXA, and the T-scores beyond a certain range can indicate that a diagnosis of osteoporosis. But you can also make a diagnosis of osteoporosis clinically, which means that if you present with a fragility fracture, and again, this is a fracture from your own standing height or less, okay?
So you could trip on a big stair, you could be clumsy, you could all these things, and you have a hard fall, and you break something.
Right.
That's a fragility fracture.
Right. So fragility fractures of the hip, spine, humerus, and sometimes the distal radius or the wrist are all diagnostic of osteoporosis without a DEXA, unless some other health problem, is identified that caused the fracture. So we say osteoporosis until proven otherwise.
Yeah.
And so if someone comes into my office, or if someone came into my office and told me that they, bumped against their refrigerator and fell and broke their hip, I don't even have to look at the report from their DEXA scan to know that they have osteoporosis. And while the DEXA scan is helpful for us to look at how a patient responds to treatment over time, it's not necessary to make the diagnosis.
So I think that's really important for a take home for people, for themselves or their family members, that if someone had a hip surgery and over age, any kind of broken hip over.
Well, really 40, but 50 is, what we consider to be the absolute age line where we say you have osteoporosis.
So if someone tells you, if your mother, grandmother, grandfather, this is men also, says, oh, I fell and broke my hip and I had to have a hip replacement.
Correct.
Or I have, my back hurts all the time because I have fractures of my vertebrae. You don't have to go get a bone density. That person needs to be talking to someone about how they're going to treat their osteoporosis.
Well, they do need a bone density.
Well, yes. But I'm sorry. Let me rephrase that. You don't have to get a bone density to call it osteoporosis. Correct. And to know that you need to seek medical attention.
And that's another area where really our healthcare system is failing its patients, because less than 20% of people who break their hip receive any follow-up related to osteoporosis within a year.
Yeah.
And that's our fault.
Yeah.
That's not Joe Smith walking down the sidewalk's fault. It's our fault.
It is, because we have that person with a fracture under medical attention getting their fracture fixed. And at that time, when you go to the ER and you have something weird show up on the CAT scan of your lung, you're getting a pulmonary referral before you leave the ER. But when you are getting your bones fixed, you are not getting a DEXA referral or a referral to an osteoporosis clinic, or even back to your primary care to discuss what you're going to do to prevent future fractures. It's just not happening. And you're right, that is an absolute failure in our healthcare system. And we really hope if you take something away from this podcast today, it's to recognize that one fracture really helps indicate that there will be future fractures if we don't recognize that a fracture over age 50 is bad bone health and we need to act.
And fractures do increase the risk of more fractures. And the risk is highest within the first few years following an initial fracture. So it even more so underscores the importance of follow-up. And it's not just about the DEXA or the prescription. There are a lot of things that we can do that don't have anything to do with medication that can really make a difference in an osteoporosis treatment plan.
So let's expand into that. We've talked a little about recognizing that we are ignoring osteoporosis, and really we want to empower every person listening to this to go to their physician if you're age 50 and over and talk about your bone health and whether you need screened for osteoporosis. If you've had a fracture or someone you know has had a fracture over 50, you need to be aggressive and you need to go talk to somebody about it. And so in recognizing that there's a lot of people out there who don't realize that they have this ticking time bomb, but then when we realize that there's a ticking time bomb, what are the different things that we can be doing?
Well, I think the first and most important thing is actually what we're doing right now, sitting down and talking to your healthcare provider about what exactly the scan shows, what your history is. Family history is also really important. And because a lot of people don't realize that, a hip fracture is osteoporosis, they don't realize that they may even have a family history of osteoporosis simply from a parent's fracture history. So sitting down and really digging deep into the person's health history, what medications they take that could be harming their bones potentially. And then, we get into the discussion of diet and exercise, because calcium and vitamin D are essential for the formation of strong bones. And 50% of people don't get enough calcium on a daily basis. And up to 80% of people can be vitamin D deficient at any given time. So those are a real area that we talk a lot about optimizing diet and using supplements as needed. We talk about screening for vitamin D deficiency, because that has to be treated with prescription medication. And then weight-bearing exercise is
Before
really
you move
important.
on, I want to throw one thing in, and then we're going to spend some serious time on that. I had a patient ask me, and sometimes I go, oh my gosh, that's such a good question that I've never ever addressed with someone before. Vitamin D deficiency, we actually can get in lab work, and we can draw your vitamin D level, and we can say, hey, you really need more vitamin D. Vitamin D is going to help move the calcium into the bone. Calcium deficiency is not regularly found with a low blood calcium level.
No.
Because calcium will be stripped out of the bone to keep the blood level correct.
And I spend a lot of time explaining that. People will come in with their labs and they say, but my calcium's normal.
So why are you asking me to take calcium?
Exactly. And what they don't understand is the physiology of how calcium works in our body, not just in our bones, but calcium is necessary for skeletal muscle function. And all muscle function, cardiac as well. I heard myself say it. I said, that's not just skeletal. And our body's going to prioritize our cardiac muscle over our bones.
Right.
So if we don't get enough calcium on a daily basis, our parathyroid gland sends a signal out to say, we need more calcium, and it comes out of the bones and teeth.
The bone. Yeah.
Exactly. The same thing happens during pregnancy as well. The body will actually pull calcium from the mother's bones and teeth to support building the fetal skeleton.
We like to say in pregnancy, that's where the baby first starts taking every single thing that the baby needs and leaves you with what's left.
Exactly.
And then it goes on for at least 18 more years. Yeah.
But it's so true. So, I mean, and really, and something that I'd like to talk about and do plan to talk about later on is how preventing osteoporosis is actually a lifelong journey. There's, and I can't remember who said it, but there's a quote that has always resonated with me, which is osteoporosis is a pediatric disease with geriatric consequences.
Oh, wow. I love that.
And so what we do to build our peak bone density as young people actually will have an impact on us as we age as well, which I think is one of the reasons why we see osteoporosis cases increasing, and why we will continue to see them increase through 2040, because what we do in our younger years does have an impact. So a sedentary lifestyle, lots of caffeine, not a lot of milk, not a lot of outside activity, sitting in front of a TV, playing video games, things like that, whether or not you smoke as a teenager and as a young adult, all have a huge impact on what your peak bone density will be. And that determines how much bone you carry into your older years, and really does make a difference.
So talk to us about what we need to be doing with our children and through our life to get to the best peak bone density. And then when we get to that peak bone density, we're in a decline. It's just how our bodies work. Mm-hmm. And then what we can do in lifestyle at that time.
So taking a step back and looking at bone formation, what we know is that people achieve their peak bone density by around the age of 25. And I'm going to speak to women because that's what I'm really comfortable talking about. And so in women, after they hit their peak bone density around the age of 25, their bone density actually stays fairly stable. Bone is being built and removed at an equal rate. Like all of our organs and bones are living tissue. And like all living tissue, old bone has to be removed and new bone built for our skeletons to stay healthy. So then we get to menopause, which is around the age of 45 to 55. And that's when bone density really starts to decline for women. And one of the primary reasons for this is the fact that our bodies stop producing estrogen. And so bone density will decline in the first year up to maybe 12 to 15%, and then proceeds at about 1 to 2% per year after that. So if we know that 0 to 25 is our time to build our peak bone density, what can people do from a young age, or what can parents do to help their children from a young age to have the strongest bones possible? And the funny thing is, it's the same answer, the same counseling that we give to our osteoporosis patients when they come into the office to talk to us. And that is, make sure you get enough calcium and vitamin D on a daily basis.
And in a world where dairy is getting more vilified, mm-hmm. and maybe it should be a different conversation for a different day, you need to make sure, if you're not doing dairy with your kids, that you are making sure that they're getting calcium and D and other sources.
Correct. And it's easy to get it from other sources. Milk alternatives are always fortified with calcium. So your oat milk, your almond milk, your soy milk, all is going to be fortified with calcium and vitamin D. You can also get calcium fortified orange juice. And even if you're not a milk drinker, cheese and yogurt are great forms of a dairy that can give you a lot of calcium and protein. But then too, with younger people, not leading a sedentary lifestyle is really important. And I know that up to a point, we can't help that we have to sit in school or at work, but getting outside, running around, playing, not being in front of a television screen, playing video games, makes a big difference. So the more your kids run around, they get exposed to that natural vitamin D from sunlight. And also, just avoiding some of the things that I think we're seeing more and more with our kids now, like caffeine intake, excess caffeine intake, excess, carbonated beverage intake, that, you're drinking caffeine and you're not getting, nutritious foods. Yeah. And then one of the biggest things that really can affect peak bone density in younger people is smoking. Smoking is terrible for your bones.
And or vaping.
And or vaping,
Yes,
yes, absolutely. It's terrible for your bones. And I know it's really hard to tell an 18-year-old that they should stop smoking because it's bad for your bones,
Yes.
but it's the truth. And bones don't forgive the way other organs in our body do. You know, you can eventually undo lung damage from smoking, but because bone moves so slowly compared to other organs in our body, you really can't get over that. So, and then if you continue to smoke and or drink excess alcohol or not get your calcium and vitamin D, things like that into adulthood, even during that, what we call the resting phase of bone, where bone density is supposed to be relatively stable, you can actually lose bone during that time as well because of lifestyle choices. So, it's really the things that I would tell young people are all the things that I would tell my own patients.
I'm so glad you mentioned that, because it really is in a world where we're trying to focus on wellness and prevention. It really is important for us to keep these things in mind to even not have to go there. But then once we get to the place where someone's told that they have osteopenia or osteoporosis, what kind of exercise? We talked about some supplements, calcium and vitamin D. What kind of exercise would we be recommending?
So weight-bearing exercise is the most effective exercise for osteoporosis. And I tell my patients that that's pretty much everything but swimming and biking. Although I do have lively discussions with some people about how biking really can be a resistance activity, but if you're just riding your stationary bike without resistance or swimming for your exercise, you're not putting your weight on your bones.
Yeah.
And that's the really important thing, is anything that in which you have to bear the majority of your body weight on your muscles and bones is weight bearing. And it doesn't have to be complicated. Walking. Yes. Walking is an excellent form of weight-bearing exercise. And you can actually walk and incorporate upper body strength training as well. Wrist weights are a great way to get your upper body involved in weight-bearing activity, and just wearing those while you walk is great. Anything that gets you up on your skeleton and moving is good exercise. And it doesn't have to be a lot. 15 minutes, 3 or 4 days a week would be better than nothing at all. And you don't even have to get your heart rate up. Unfortunately, people do have activity limitations as they grow older. And we do see a lot of patients with mobility problems by the time that they're in the office receiving the diagnosis of osteoporosis. So if your patient really has trouble moving, a physical therapist is also a great resource to help a person come up with an exercise plan that will be safe for their bones.
Absolutely.
Because there are some things you don't want to do when you have osteoporosis because of the force that it can apply to your bones. Things, especially with someone with osteoporosis, any activity that involves a lot of bending from the waist is not recommended, because even just bending at the waist can exert enough force on the bones of the spine to break them. So, staying upright and doing things like walking or working with a physical therapist can really be helpful.
And then I just want to kind of cap this off with the treatments for osteoporosis. And we talked about this in our former episode on just sort of the different drug classes. But I will say there are certain medicines, Amber and I have mentioned it multiple times in the podcast, that just have an aversion. I don't know whether Facebook decided they hated it and then everyone went along with it. But gosh, try to get someone on a statin, try to get someone on metformin. Metformin's a great drug, people. Please leave it alone. And almost all the osteoporosis medicines. And I don't know whether people have been misinformed or whether it's something that doesn't hurt necessarily. So if they haven't had a horrible fracture, they're thinking, it's not worth the treatment. But we really have resistance to people doing these treatments, but it is so important. And I would love to be able to say anything to help decrease the resistance to treatments.
Well, I think I know this is something that I've struggled with in my practice and spent a lot of time early on being really frustrated with, because as you said, there is a lot of resistance to taking medication for osteoporosis. And I think that part of it is that there were some studies that came out in 2008 that indicated that long-term use of certain osteoporosis medications wasn't helpful and could be harmful. And I really think that a lot of the resistance now still falls into that because people don't understand that there are different types of medication for osteoporosis, and that this 2008 study focused on just one type of osteoporosis medication, the bisphosphonates. So that would, just for those of you who don't know what bisphosphonates are, that's your Actonel, your Fosamax, and Boniva are the three most commonly prescribed. And people took this brush and brushed all of the osteoporosis medications with that bad press that bisphosphonates had in 2008. But the truth is, we have so many other options that are safe for long-term use and are actually much more effective than what we had 15 or 20 years ago. That's the other thing about osteoporosis. Up until the early 2000s, we didn't have any prescription medication to treat it.
Wow.
And just in the past 20 years, we have been able to put together this little arsenal of medications that we can use. But as you mentioned, unfortunately, there's still a lot of resistance, and maybe it is partly that it doesn't hurt. And I do, sometimes at the end of the day, I just have to tell people, look, I can't make this decision for you. It's my job to make you understand what the recommendations are and also to understand the consequences of not taking medication.
Right.
But promise me that if you break a bone between now and your next appointment, give us a call and let us know, because that changes things. And we may need to revisit this resistance and really, get to the bottom of it and find the right treatment plan to prevent future fractures.
It's a great approach. I really think part of what we're trying to do in healthcare is not help people live into old age alone, but to help people live into old age with great quality and the ability to do the things that they want to do. And when you say you lose your ability to drive, you lose some independence, you lose your ability to live at home. For any geriatric, any of our older people that we love taking care of, when you ask them what's important to them, it's keeping their independence. And if I said, do you want to live to be 100 or do you want to live to be 90 and be independent the whole time? The answer is always obvious.
Right.
So if this helps people to keep their independence, it's a really important conversation to have. We've started our bone health and osteoporosis clinic in our clinic a lot with the coaching and guidance from Katie. And because we feel like it is something that's being ignored and we didn't have the resources that we wanted, so we built the resources ourselves. But this is a conversation that's worth having. This is, next holiday when you're sitting with mom and grandma and dad and grandpa, you need to be having these conversations about how to keep our bones healthy as well. It's been ignored for too long.
It has, and it really is important. And I think that's probably, if I really sit down and think about it, what really ignited my fire was, that it doesn't have to be this way.
Yeah.
We can do better. And I'm so excited for y'all that you have this brand new DEXA machine and that you're going to be able to help so many more people as a result of having this available in the community.
Thank you so much, Katie, and thank you for the work that you've done in this field. It is life-changing, and preventing illness, you can't always predict what would have happened, but you've done a lot of amazing work in keeping people healthy. We appreciate you being here today.
Thank you so much.
We like to leave you on a good note. Today's Tell Me Something Good comes from Jessica. She's our amazing team lead and medical assistant that we could not live without. So Jessica, tell me something good.
Something good would be my grandma is about to be 93, and she's in great health, and she still lives with her husband who's 91. So just very grateful and thankful that she's still in good health, and it's about to be her birthday.
Yay, we love celebrating people we love. So thank you for joining us this week, and until next time, take care of yourself.